Thank you very much. Very good to be here in Modena again at this interesting symposium. I've been given the task of following on, I think, from the last speakers to talk about mechanisms of the development of cardiovascular disease. And I'm grateful to the last speakers for setting the scene in terms of cardiovascular risk in COPD patients. Just to start with, I suppose, this is just some information from the ECLIPSE study, which is a convenient sample of COPD patients recruited from largely secondary care. And what it looks at simply is to look at cardiovascular disease, and this is patient-reported cardiovascular disease in a group of COPD patients, smokers and non-smokers, who are roughly matched to the COPD patients. And you can see that the pink bars here are always higher no matter what you ask the patient, whether they have heart trouble, hypertension, angina, stroke, either measured hypertension. So it's quite clear that whatever the cardiovascular disease is, it's commoner in COPD patients, and it certainly has an effect on outcome. Because if you look at those patients with COPD who have cardiovascular disease, and you look at a reasonable outcome, which is death, you can see that those with cardiovascular disease, as you might expect, really, have a worse outcome here, the ones with cardiovascular disease compared with those without cardiovascular disease. It's interesting also to look at what these patients have, what they look like. And those patients with cardiovascular disease, as you've heard already, and it's obviously confirmed in this study, are the ones with a higher BMI. And functionally, they're worse off. They are more breathless. They have a higher MRC dyspnea score. They have a lower exercise tolerance as measured by the 6-minute walking distance. They have a poor health-related quality of life as measured by the St. George's Respiratory questionnaire. And they have more systemic inflammation as measured by these factors here, IL-6, IL-8, and fibrinogen measured in peripheral blood. And I'll come back to that theme towards the end when I talk about inflammation in COPD. There are a number of proposed mechanisms, and what I'm going to tell you, I'm not going to say that there is a mechanism. There probably are multiple mechanisms. You heard one already, and that is shared traditional risk factors. As you might expect, cigarette smoking is the shared factor, also the presence of diabetes or hypertension, hyperlipidemia. Now, what information do we have about that? And I'll come on to that just later on. There's also a feeling, not in terms of development of atherosclerosis, but in development of cardiac dysfunction, that lung overinflation in COPD may have mechanical effects causing left ventricular diastolic function. We've known for 30 years that there are neurohumoral effects in COPD. There's activation of the sympathetic nervous system. That's been known about forever, and that may have some effect. There's a kind of pulmonary hypertension model, if you like, although I'm not absolutely convinced by this, that might result in left ventricular diastolic dysfunction. There's some shared genetics. There are polymorphisms in both diseases on MMP, epoxide hydrolase, glutathione transferase. And there's also a function of aging. Aging itself, both cardiovascular disease, atherosclerosis is an aging disease, so is COPD. And finally, there's systemic inflammation. And I'll touch on each one of these in brief, and I'll touch more on the systemic inflammation as a possible cause. Now, what about cigarette smoking? Well, here's a study which looks at atherosclerosis. It measures atherosclerosis actually as the mean carotid intermedial thickness or the percentage of carotid plaque. It's a Japanese study, and what it looks at are a group of control non-smokers, smokers, and smokers with airflow limitation. So you might expect that if these smokers who are matched to the smokers with airflow limitation, you might expect that these would have exactly the same amount of atherosclerosis. What is clear from this study is that there seems to be an effect of COPD, or the development of airflow limitation seems to increase the amount of atherosclerosis. So although I'm not denying, there's no doubt that cigarette smoking is an important aspect, there may actually be an effect of COPD itself in producing an increase in atheroma. What about shared other comorbidities? Well, we've heard from Klaus already, that nice study from Maastricht, which showed the relationship between all of these comorbidities, or the numbers of comorbidities that occur in COPD patients. And certainly if you look at diabetes, hypertension, cardiovascular disease, this is again a David Marnino study, and you look at the risk of death or even the risk of admission to hospital within 5 years, you can see that adding these comorbidities to cardiovascular disease, having hypertension or diabetes, increases the risk, and these are the different gold stages here, the risk in this case of death. So there is probably an interaction. Certainly those patients with multiple comorbidities, particularly these other ones in association with cardiovascular disease, would increase the risk of cardiovascular disease. What about lipids? Is it just that patients with COPD have an atherogenic lipid pattern? No, they don't. And this is a study from some time ago, as you see, which looks at various lipid profiles here, but also looks at lipoprotein A, which is a well-recognized risk factor for increased cardiovascular risk. And you can see that there's no difference between the COPD and the healthy smokers in terms of the lipid profile. In fact, if anything, the lipoprotein A is higher, shown in the next, I think, here in the healthy smokers as compared with the COPD patients. This just shows a cutoff point here of less than 14 milligrams per DL of lipoprotein A. So there's not much evidence to suggest that lipids are involved. What about overinflation? Well, there's an interest in overinflation. Overinflation measured here by the ICTLC relates to death in COPD patients. And there certainly is a relationship between the filling of the left ventricle, so this is left ventricular end diastolic diameter, and overinflation. So certainly overinflation in COPD probably has an effect on left ventricular filling and on function, as shown here. And the filling, these two measurements here of left ventricular filling are different in those patients with overinflation compared with those patients who don't have overinflation. So there is probably an effect on left ventricular filling, and hence left ventricular diastolic function in those patients with overinflation. There's a lot of evidence, and I'm not going to show it here, but there's a lot of evidence in the past to support neurohumoral activation in COPD. There's evidence of reduced baroreceptor activity, a decrease in heart rate variability. There's increase in norepinephrine in serum and in urine, activation of the renin-angiotensin system. And using this technique of microneurography, you can show that there's definitely evidence of activation of the sympathetic nervous system in COPD patients. And the thought is in COPD patients that there is, with neurohumoral activation, there's an interaction here between systemic inflammation and neurohumoral activation, a reduction in heart rate variability. Neurohumoral activation interacts also with increased arterial stiffness, which is a risk factor for cardiovascular risk, and it produces endothelial dysfunction, and that leads to the cardiovascular disease. And certainly this may be one aspect which may relate to the cardiovascular disease in COPD. What about systemic inflammation? Well, one of the problems with systemic inflammation, Klaus showed actually another slide from this paper by Alvar Augusti. Systemic inflammation really is very poorly defined. Most people think of systemic inflammation as just measuring one systemic inflammatory marker. They rarely measure it twice. They just measure it once and say if you've got an elevation in this systemic inflammatory marker, you've got systemic inflammation. This was an attempt in this study to try and define systemic inflammation. Now, it is an attempt. It's not the end story. It is an attempt. And the suggestion here was to look at inflammatory biomarkers measured in peripheral blood, white cell count, high sensitivity CRP, IL-6, and fibrinogen, which seem to relate in this population to COPD. They were elevated in COPD patients. So there's a choice here of 4 biomarkers, and the definition that we came up with was that if you had an elevation above the 95th percentile in the COPD population of 2 or more of these systemic biomarkers, then we would define that arbitrarily in a way as systemic inflammation. If you actually look at, this is the Eclipse cohort again, you look at when we recruited the patients here, you can see that 2 of those biomarkers were elevated according to this definition in 28% of the population, and 43% of the population did not have those biomarkers elevated. When you actually moved on to measure it again, you can see that of the original 28%, 56% still had 2 elevations of these biomarkers, and 70% of the patients, of the 43% who didn't have any elevation of these 2 biomarkers, didn't have elevation of the biomarkers at year 1. So that defines what we defined as persistently systemically inflamed individuals. 2 biomarkers elevated and 2 separate occasions. And that, as Klaus mentioned, it doesn't occur in everyone. It occurs in about 16% of the population. Whereas about 30% of the population, if you do the maths, don't have any systemic inflammation according to this definition. Does it matter? Yes, it does. Here is cardiovascular disease in the group with sustained systemic inflammation compared to those without sustained systemic inflammation. So higher a number of patients. And again, I must mention to you that this is patient-reported cardiovascular. It's not the best measure, but it's patient-reported cardiovascular disease. So you can see that there are a higher proportion of those patients with sustained systemic inflammation have cardiovascular disease. And there's a big impact on mortality, almost 6 times the mortality in those with sustained systemic inflammation compared with those without sustained systemic inflammation. Now, if you want to look particularly at atherosclerosis, one measure that you can make is coronary artery calcification. Coronary artery calcification relates to the atherosclerotic burden, if you like, in the lungs. And we were fortunate in the Eclipse study to be able to do this by measuring coronary artery calcification from the chest CT scans that we had. And it doesn't matter how you measure this. If you look at the COPD group, smokers and controls, you can measure the Agatston score, which is the standard way of measuring coronary artery calcification, as shown here. Or you can use the MESA score, which accounts for gender, sex ratio, and age. It doesn't matter which way you measure it. You can see that in the COPD group, there's a higher amount of coronary artery calcification than the control smokers and non-smokers. The age is slightly different. The FEV1 is not any different in this. The FEV1 here is lower, obviously, in the COPD group. So one of the things that you would say is, well, of course, these patients have more cardiovascular disease. You might expect there's more. But if you actually subdivide that, and I'll show the data, and look at those patients who have no reported cardiovascular disease, you still find more coronary artery calcification in that group. And is it important? Yes, because it relates, again, to survival. Here's the quartiles here of the Agatston score here, and you can see the higher Agatston score here, particularly an Agatston score greater than 400, really relates to outcome. And if you look in those groups with coronary artery calcification also relates, as you might expect, to poor clinical outcome. Lower MRC, lower 6-minute walking distance, higher St. George's Respiratory Questionnaire, higher Bode Index. Interestingly, more emphysema and more systemic inflammation is shown here. And if we look actually at what we showed before, that is sustained systemic inflammatory group, that group who had the 2 or more of these biomarkers sustained elevations in those on 2 occasions, you can see again that there's quite a difference here in the amount of coronary artery calcification in that group. So systemic inflammation in this group relates to coronary artery calcification. What about endothelial dysfunction? That's the suggestion. The suggestion is that the COPD effect is an endothelial dysfunction. Well, there's no doubt that in cigarette smokers, there's endothelial dysfunction. This is the way to measure endothelial dysfunction. There are various ways of doing it, but this is the best way. And it's basically using plethysmography really to look at forearm blood flow and infusing something like substance P to try and produce this nice curve here of the change in the infused arm of blood flow. And certainly in cigarette smokers, there's a decrease in vasomotor tone, if you like. There is an endothelial dysfunction in cigarette smokers. Another way of looking at endothelial dysfunction is the release, following substance P infusion, of TPA from the endothelium. And again, there's a reduction in the release of TPA in cigarette smokers compared with non-smokers. What about COPD? So there's certainly an effect on endothelial function in smokers. What about COPD? Well, in COPD, there's no effect at all. So what we've taken here is a group of control subjects who are exquisitely matched to the COPD. Same shoe size, eye color, everything. 2 years it took us to get the same. So these are smokers who have smoked exactly the same amount as the COPD group, and they are otherwise very well matched. There's really no significant effect on vasomotor function here, and no significant effect on TPA release. Now, others have shown, using various techniques, flow-mediated dilatation, that there may be an endothelial effect. This is the best way of measuring it. We couldn't find an individual COPD effect, although, sure, this is not normal in endothelial function because these have been cigarette smokers and there's an effect there. Flow-mediated dilatation probably relates to other things too, particularly arterial stiffness. And that leads me on to another marker that we've measured to assess cardiovascular risk, and that is arterial stiffness, simply measuring the time it takes for the pulse wave to go between your carotid and your femoral artery, which has been shown to be related to cardiovascular outcome, as shown here, relates to mortality in population studies. When we looked again in our very exquisitely matched control group of smokers who smoked the same as the COPD group, and COPD, you can see that however you measure it, either as the pulse wave velocity or looking at the pulse wave analysis using the augmentation index, you can see that there is a change here in the COPD. There's an increase in pulse wave velocity, stiffer arteries, that means. So here's the increased arterial stiffness. Others have also shown that this increased arterial stiffness occurs in COPD, but does relate to age. It's what happens in your arteries. Your arteries get stiffer as you age. But you can see that for every age group here, there's an increase in arterial stiffness or an increase in aortic pulse wave velocity in the COPD group compared with the control group here at any age. What we found interesting was when we just did the usual correlations with everything we could think of, one of the correlations that we found was the relationship here between pulse wave velocity and emphysema severity. And in fact, when we do a multiple regression analysis, emphysema is an independent risk factor for an increase in pulse wave velocity. And that made us think of what the mechanism that might link emphysema and arterial stiffness could be. So here's the relationship again. Of course, it could be just an aging phenomenon. Telomeres are one way of measuring biological age as opposed to chronological age. And you're probably aware that in emphysema, and cells in emphysema, there's a decrease in telomere length, so an accelerated aging pattern, if you like, in the cells in emphysema. And also in the hypertension literature, there's been a relationship between telomere length, shortened telomeres, accelerated aging, if you like, and the pulse wave velocity. Now, we haven't got the studies are being done at the moment to see if pulse wave velocity relates to telomere length, but it could be that this is an accelerated aging phenomenon both in the lungs and in the arteries to produce the increase in arterial stiffness. One other thought that we had came from this little study here, which is a study from David Lomas's group some years ago, which looked at skin wrinkling. And you can measure skin wrinkling, if you like, and I'm happy to do that of anybody in the audience. You can see it, but I can tell from your crow's feet there. I would say 65, no, I'm not sure what age. However, you can measure it, and I'm happy to do that with anyone in the audience if they wish to measure the Daniel index here. And David Lomas's group found there was a relationship between wrinkling and emphysema. And this again made us think of what, of course, happens. Aging in the skin and in the arteries is associated with degradation of elastin and replacement by collagen. That's what happens in both of those instances. So what we did was we measured elastin degradation in the skin, and we've also got some studies where the preliminary data I've got seems to suggest the same is going on in the arteries. But we used the skin as a surrogate to determine whether there might be systemic elastin degradation in the skin, which might relate to what was happening in the arteries. And you can measure elastin degradation by simply measuring the amount of the dermis that's occupied by elastin. As the elastin degrades, more of the dermis is occupied by elastin. What we were able to show is that compared again with our exquisitely matched control group, COPD patients, both in sun-exposed skin, and I have no idea why we did sun-exposed skin in Scotland, because sun-exposed skin and non-sun-exposed skin is exactly the same in Scotland. But if you want, we did it in both cases, and you can see that there's an increase in elastin degradation in the skin. Now this is the first, actually, I think, report of systemic elastin degradation as a systemic effect in COPD. So there's in this group, the arterial stiffness was, it was more arterial stiffness, there was more emphysema, obviously, and when we actually looked at the correlations, we found that arterial stiffness, measured by pulse rate velocity, related to emphysema severity. Elastin degradation in the skin related to the FEV1, related to emphysema, and it related to pulse wave velocity. So, and our preliminary data might suggest that the same thing, this elastin degradation, is occurring in the arteries. So here's the relationship between elastin degradation in the skin and pulse wave velocity. And we also looked at what might be degrading in elastin. We looked at MMP9, and MMP9 gene expression relates to elastin degradation. That's interesting because we're aware that in COPD patients, if you take peripheral blood monocytes, there's an increased release in MMP9 from COPD patients' peripheral blood circulating monocytes. And again, in the hypertension literature, there's a relationship between circulating MMP9 levels and arterial stiffness. So this might be a mechanism, at least for that increase in arterial stiffness, which might relate to the development of atherosclerosis and is a target for treatment. Statins will reduce MMP9s, for example. So, and statins have also been shown to reduce in other literature, in the rheumatology literature, to actually reduce arterial stiffness. So there's a possibility of effect here. Just lastly, I wanted to, Klaus, I put this slide in last just to remind me, Klaus mentioned about exacerbations and so on. Well, there's an increased risk of myocardial infarction in exacerbations of COPD. And in a study that we did, about 3%, however you want to define exacerbation, if you take the best definition of myocardial infarction, you'll find about 3% of patients have a myocardial infarction during their exacerbation. That's a lot of patients. And we looked at another marker of increased cardiovascular risk, and that is the activation of platelets. It's platelet monocyte binding, and again you can see platelet monocyte binding, even in the stable state, is increased in COPD, which might increase the cardiovascular risk, but it increased even further in exacerbations of COPD. And there's been a study just published quite recently from, again, the East London group, looking again at an increase in systemic inflammatory response in association with changes in cardiac function in exacerbations of COPD. So this might be one mechanism whereby there's an increased risk of myocardial infarction in exacerbations of COPD. So to finish with what I've shown, not from the other, I'm not going to mention I haven't even mentioned activity, which is clearly very important and another co-risk factor in COPD patients who are quite inactive. In terms of vascular function in COPD, I think we are starting to get to near where we think we might decide on a more specific intervention to try and reduce cardiovascular risk. Smoking certainly affects the endothelium. I've shown impaired vasodilatation, impaired fibrinolysis in this group, but COPD itself leads to systemic inflammation and oxidative stress. I haven't mentioned the oxidative stress part, but there's a whole literature related to oxidative stress and the development of arterial sclerosis. That inflammation will, of course, lead to increased adhesion molecules, leukocyte adhesion, even the lipid peroxidation that might be produced as increased oxidative stress, and the uptake of lipids into macrophages produces foam cells. So there's a real mechanism there in terms of the development of atherosclerosis. There's also increased platelet activation and platelet monocyte binding, as I've shown. And the extracellular matrix might be quite important too. Elastin degradation, medial elastocalcinosis, as I've shown in the coronary artery calcification, occurs and might be related to the increased arterial stiffness, might be a phenomenon related to the arterial aging, and even a failure of repair. I haven't shown some of the data that's coming out looking at stem cells and the decrease in stem cell release in COPD patients. And finally, of course, the vascular smooth muscle cells moving into the atherosclerotic plaque. So I think we're beginning to determine what the mechanism might be, at least of the atherosclerosis or the endothelial dysfunction that occurs in COPD. Thanks for your attention.
Thank you. Thank you, Professor MacNee, for your very interesting presentation. Another link between pulmonary emphysema and cardiovascular dysfunction could be the depletion in muscle mass, for example. The muscle pump is a determinant of a cardiovascular response to exercise, and this link could explain the efficacy of pulmonary rehabilitation in pulmonary emphysema. What do you think?
Well, there was we thought that might be true, and in fact there's a study called ERICA, which is going on in the UK at the moment, which is studying just that, is looking at the interaction between muscle dysfunction and cardiovascular disease. So far, we haven't found any interaction. In other words, I mean, just simply looking at, do those patients who have muscle dysfunction, loss of muscle mass, have an increased in cardiovascular disease or cardiovascular risk, such as increased arterial stiffness? No, they don't. Mm-hmm. So it may be that there's a relationship, and the relationship may be that, I mean, there's an interrelationship between a whole host of these comorbidities. For example, I didn't show the relationship between osteoporosis, emphysema, and increased arterial stiffness and coronary artery calcification. There's a whole relationship there. So it might be that this is just part of that relationship, but direct interaction between the muscles and the cardiovascular disease we haven't been able to show in the ERICA study, interestingly enough.
Please.
Monica.
Thanks, Bill. That was a very nice talk. And no, I don't want you to do any sort of wrinkle evaluation right now at all. Just let me know. So don't come near me.
21.
Don't come near me. Yeah, nice try. I was intrigued with your elastin data. That's sort of an interesting way of looking at COPD and aging and that intersection. And you talked about MMP9, and this is just a very specific question. I wonder about, have you looked at any other MMPs? I'm thinking about MMP12. Oh, and what about 12, given Gary Honeyhockey's data on the SNP that's associated with emphysema? No,
we didn't find. We find it with MMP2, but not with MMP12.
Interesting. Okay, thanks.
Professor Cosio.
I'll look earlier, Manuel. I'll look earlier. I will. I'll look earlier. I mean, you could measure your arterial stiffness, at a very early stage, and really predict your outcome. Early stage. Is that the question? No. Good.
I think this is very interesting because it brings things together that I'll go a step farther in a second. But arteriosclerosis is obviously, we know now, even though we didn't think so, is an autoimmune disease. Interestingly enough, COPD, some people in this room think that it might also be an autoimmune disease. And one of the antigens that had been, described to be possibly responsible of part of this autoimmune reaction are antigens of elastin. Elastin, of course, is also in the arteries. Elastin, of course, is also on the skin. And we also know that people with autoimmune diseases, they are multi-organ. And not only that, but, antigens can mimic one, tissue to another and so on and so on. And, the other thing, of course, that once we have an autoimmune disease, is very, very, very common to have a generalized inflammation. So all could be brought together. We are trying to, again, and I would invite again is that to just, as I said before, let's center in the pathophysiology of the disease we are interested, that's COPD. And rather than maybe by understanding better what happens in COPD, we can explain what you just very beautifully just taught us now.
No, I agree. And just moving on from, I mean, although that elastin antibody story has not been absolutely replicated, I think, but I mean, it's an interesting one. One interesting feature that's just come out recently, again from the ECLIPSE study, is that we measured desmosine. Now, I mean, those who have been in Man will remember desmosine. Oh dear, can you measure desmosine? I mean, well, we think we have the best measurement of desmosine that we could possibly get, and of course we measured it in peripheral blood, and we thought there'd be a relationship with emphysema. No relationship whatsoever with emphysema. What there is, though, is there a relationship with cardiovascular disease. And I think probably what we're measuring is coming from the vessels, from the degradation of elastin in the vessels more than our vasculature more than anything else. So I think we're going to look at that again, looking at desmosine in relationship to arterial, to coronary artery calcification, which would be an interesting thing. So I think, yes, and I'm all for pulling it all together in one kind of theory. I mean, I'm really, I think that's the way forward. I think this, looking at it in different areas, I mean, that's what we're trying to do, to link the arteries and the emphysema and the...
Last brief question, Professor Raven.
Just very, very quick one. I think you should not be too disappointed not to find any vascular smooth muscle or striated muscle correlations in ERICA in anything. I think the biology of these may be very, very different, and it may just be coinciding rather than anything else, because they may be phenotypically very different in a given individual. But going from that, try to link the risk and the exercise in this. One of the biggest inducers of inflammation and oxidative stress to the muscle is exercise. So I never came to grips how a low level of exercise that obviously sort of, affords structural changes, still being the oxidative stressor, you can measure it, why would it be in your scenario so beneficial? Could you speculate on this?
I think it's really difficult to answer that question, because, rehabilitation should, is oxidative stress, and maybe you need just enough oxidative stress to increase repair mechanisms. I suppose that might be one idea, and if you have too much, then you reach problematic. I think that is a difficult question to answer, but it may be to do with the balance between the oxidative stress and any increased repair mechanisms that may occur in the oxidative stress.
Okay, thank you.
Well, the other thing is that rehabilitation, of course, exercise reduces arterial stiffness. Very easy.
Okay, thank you very much again, Professor MacNee.